Welcome to Wisdom Radio. I'm Dr. Rusty Hoffman, professor of interventional radiology at Stanford, bringing you a direct line to critical research and interventional updates. Powered by AI, curated by experts. Let's get started.
The interception of extreme cold and surgical precision. Because for anyone who's suffering from chronic pain, or for our healthcare systems just constantly fighting the opioid crisis, finding targeted, non-addictive alternatives it's the holy grail.
And our sources suggest the answer might lie in a technique that, on the surface, sounds totally paradoxical. You're intentionally freezing a nerve to stop its pain signals.
Cryoneurolysis, the precise destruction of neural tissue using controlled cold.
Exactly.
So our mission today is to unpack how this technology has moved, well, far beyond the niche. We're going to explore how advances in imaging, a deeper understanding of nerve regeneration, and I think this is the big one, a massive recent shift in regulatory policy have made this a primary option.
A legislatively endorsed option, even for things like palliation and functional restoration.
We're going to look at the exact science of the freeze and some applications that I think you will not see coming.
Let's start with the science then, because getting this procedure right requires a kind of precision. I mean, cold therapy for pain relief is ancient, right? But modern cryoablation really begins in 1961 with a neurosurgeon, Irving Cooper. He developed the first closed cryoablation device. It used liquid nitrogen. And his first target was actually treating movement disorders, things like Parkinson's.
So the basic idea of freezing tissue to stop a neurological signal, that's decades old, but now we're applying it to peripheral pain, and that must require just an intense level of control.
That's the entire game. The key is we're not just freezing the nerve randomly. The goal is to achieve a very specific controlled injury. It's called Sunderland Grade 2.
Sunderland Grade 2, and the medical term is axonotmesis.
Axonotmesis, yeah.
That sounds very technical. Can you break down what that specific grade of injury actually does for pain relief?
It is the sweet spot. You have to hit a temperature that's cold enough to cause damage, so that's below negative 20 degrees Celsius. But, and this is crucial, it has to be warmer than negative 100 Celsius. In that very narrow band, you get destruction of the nerve's internal wiring. So the myelin sheath and the axon, that's the axonotmesis.
So the signal pathway is gone. But why that precise temperature range? What happens if you go too cold?
Because you have to preserve the nerve's outer structure, specifically the connective tissue sheath, or what we call the endoneurial scaffold.
The scaffold, so like a conduit or a roadmap for the nerve.
That's a perfect analogy. Think of it as the nerve's original roadmap. If we destroy that roadmap entirely, which is what happens if you go too cold, the new nerve growth it wanders off. It becomes a painful, disorganized knot of nerve endings, the neuroma.
Right.
And that could be worse, much worse, than the original pain.
So by preserving that roadmap.
Exactly. It allows for highly predictable regeneration. The axon can grow back right along its original pathway. And this is huge because it gives you pain relief that lasts months, much longer than a local injection, but without that high risk of neuroma formation you see with, say, heat ablation or just cutting the nerve.
That's fascinating. You're destroying the nerve just enough so it can regenerate correctly. But what if you miss? What if you underfreeze it? Is the risk just that the pain comes back faster?
It's actually worse than that. If you underfreeze, you get what's called a Sunderland Grade 1 injury or neuropraxia.
Okay.
You're essentially just stunning the nerve. You get a temporary block, which feels like temporary relief, but you don't get that crucial axonal degeneration. The internal structure is just stunned.
And when the stun wears off?
The patient's symptoms can worsen substantially. The most common and bad outcome here is something called allodynia.
Allodynia. That's where a non-painful stimulus becomes painful, right?
Exactly. The simple brushing of clothing against your skin can cause intense suffering. So avoiding that insufficient freeze is paramount for success.
And avoiding that insufficient injury, hitting that Goldilocks zone, that brings us right to the need for advanced imaging. You can't do this blind.
Oh, absolutely not. Percutaneous cryoneurolysis. Going through the skin with a probe relies entirely on tools like CT or high-resolution ultrasound.
Imaging is non-negotiable.
It is. Ultrasound, or US, is fantastic for superficial things, nerves around the ankle, and you can watch the ice ball grow near the skin. But, and here's the technical catch, the ice ball is sonopaque.
Sonopaque?
It just means it's opaque to sound waves.
Right.
The ice is so dense that ultrasound can't see through it. It's like trying to see the other side of a really thick fog bank.
So if you're targeting a deep nerve near the spine, for example, you can see the near side of the ice ball, but you have no idea if you've actually reached the target on the far side.
Or what's just beyond it, exactly. For that, you need CT guidance. CT lets us see that deep margin, and it lets the interventional radiologist position the probe with incredible accuracy.
Okay, but that introduces a safety concern.
Yeah.
How do you stop that extreme cold from spreading to, say, the bowel or the rectum when you're working deep in the pelvis?
That seems incredibly risky.
Yeah.
Well, we don't just hope for the best. This is where the ingenuity of interventional radiology really shines. We use protective maneuvers,
Okay.
techniques called hydrodissection or pneumodissection. Basically, you're infusing fluid saline, usually, or sometimes air or CO2, into the tissue planes right next to the target.
So you're creating a temporary barrier.
You're physically pushing those vulnerable structures, the bowel, the skin, away from the cryozone, and you're using space itself as insulation.
And this allows for safe ablation deep in the body with just local anesthesia.
Right, avoiding complex surgery. This level of precision, the equipment, the training, it all sounds expensive. Which brings us to the really crucial part of the story, the regulatory side. Why hasn't this been mainstream until just recently? The simple answer is money and paperwork. For a long time, cryoablation was limited because the Centers for Medicare and Medicaid Services, CMS, made doctors use old, non-specific billing codes or CPT codes.
And those codes for just general nerve destruction, they didn't really recognize the cost or the complexity of cryoablation.
They offered inadequate payment. I mean, to give you a stark contrast, the old code, 64620, so for an intercostal nerve procedure, it paid around $175 in 2022.
$175.
You simply cannot sustain the cost of the specialized probes, the generator, the advanced imaging time. It just wasn't viable.
So no matter how good the procedure was, if the reimbursement didn't cover the tech, adoption just stalls out.
Precisely. And that all changed dramatically in October of 2015. That's when CMS approved 3 new Category 3 CPT codes specifically for cryoablation using advanced imaging. That was the catalyst.
Okay, so for those of us who don't speak coding jargon, what's a Category 3 code and why was that so important?
A Category 3 code is basically for emerging technology. It's a signal from CMS that this technology is promising enough to be tracked, to be reimbursed, and to be studied. It's not permanent yet, but it's on the path.
It's a huge vote of confidence.
It is. And by creating specific codes for cryoablation, CMS signaled that this procedure was legitimate, valuable, and worth investing in.
And that validation came with a massive shift in payment.
A huge shift. The value recognized the complexity. For example, the new code 0442T for a nerve plexus, or a large truncal nerve, was valued at over $5,000 for a hospital outpatient setting in 2020. That change finally allowed interventional radiologists to integrate this into their daily practice. It fueled the expansion we're seeing right now. That financial endorsement just opened the floodgates. So let's talk about some of the targets. Let's start with a classic example that needs that deep precision. The pudendal nerves. The pudendal nerves are the main sensory nerves for the pelvis and perineum. Pudendal neuralgia is a debilitating chronic pain condition. This is a perfect case study for the whole workflow.
So you don't just jump right into freezing.
Absolutely not. First, you have to do a diagnostic nerve block. You use local anesthetic, confirmed under CT, to make sure you're at the right nerve.
You're proving that this specific nerve is the true culprit before you commit to destroying it.
Exactly. If the patient gets relief from that confirmed injection, then they're a great candidate. And with CT guidance, the procedure is safe. You avoid all the nearby pelvic organs. And what's really crucial here, this is a true clinical example of benefiting from that induced neuroregeneration we talked about. Many of these patients already have underlying nerve damage. The new regenerated axons post-cryoablation give the patient a reset, often resolving pain pathways that were scarred or injured years ago.
And it's not just for chronic trauma. I imagine this is huge in palliative care for cancer pain.
Absolutely. And if you move higher up the torso, cryoablation has major applications for visceral pain. So abdominal pain coming from the organs. That's often covered by that high-value code, 0442T.
A target there would be the celiac plexus, right? For intractable pain from pancreatic cancer, for example.
Yes. And cryoablation is often preferred here over the traditional method, which was injecting neurolytic agents like alcohol.
Why is that?
Fewer gastrointestinal side effects, for one. Plus, it works exceptionally well in scarred areas, maybe from prior radiation or even previous alkaline neurolysis, where a liquid agent might not spread evenly enough to cover the whole nerve bundle.
And if the celiac plexus isn't an option?
There's an alternative pathway. You can target the splanchnic nerves. These nerves carry the pain signals from the celiac plexus up toward the spinal cord, and studies show targeting them is highly effective for pancreatic cancer pain, even if the patient didn't respond to a celiac plexus block. Okay, that's incredibly powerful work in pain management. But now we get to the part of the sources that really surprised me, where we step completely outside of pain relief, applying cryoneurolysis to the vagus nerve for obesity. This is where interventional radiology starts to collide with metabolic health. The vagus nerve plays a big role in controlling satiety, that feeling of fullness. And it turns out disrupting that signal can lead to decreased appetite and weight loss.
So we're talking about a CT-guided procedure targeting the posterior vagal trunk. What did the pilot trials actually show?
The results are pretty eye-opening. Subjects in the trial lost an average of 5.6% of their total body weight.
Which is significant.
It is. But the really striking number was behavioral. A staggering 68.4% of participants reported having much less appetite.
Wow. So if this pans out, interventional radiologists could be offering a minimally invasive alternative to surgery for obesity, which then impacts diabetes, cardiovascular risk. The list goes on.
It's a whole new frontier.
It really is. Let's circle back to more localized pain and cover the extremities, often under CPT codes 0440T for upper and 0441T for lower.
Starting with the lower extremities, a massive focus today is on chronic osteoarthritis knee pain. The targets are the geniculate nerves.
Okay.
You treat 3 specific nerves at the same time, the superior lateral, superior medial, and inferior medial, and you guide the probes using bony landmarks around the knee.
But why freeze nerves in the knee? Isn't surgery the ultimate fix for severe arthritis?
It is, but not everyone is ready for it or even eligible. So cryoneurolysis does 2 things here. First, it can buy patients years of improved function before they need that total knee replacement. And second, we have level 1 data now showing that it actually improves pain outcomes after the total knee replacement surgery.
So it's a bridge. It helps with the pain before and after the big surgery.
It's a perfect bridge.
That's a clinical win. Another critical lower extremity target is the sciatic nerve.
Absolutely. While we use it for some cancer pain, the sciatic nerve is a target for managing severe post-amputation pain, specifically stump allodynia and phantom pain.
And you can target it at different locations.
Right. You can target it proximally up in the pelvis or more distally in the back of the knee, depending on where the patient's pain originates. It offers incredible flexibility for these really debilitating conditions.
And what about smaller nerves, the ones that get nicked during orthopedic surgery or from trauma?
We see it used successfully all the time on nerves like the sural and saphenous, which often get injured during things like an Achilles tendon repair. And in the upper extremity, the ulnar nerve is a very common target for entrapment or compression neuropathies at the elbow.
Okay, so last but not least, we have to talk safety. We've hit on the risk of underfreezing, but what are the absolute contraindications, the no-go scenarios?
Well, beyond your standard issues like an active infection or if the patient can't clot their blood properly, there are specific cold-related ones you have to avoid. Pyoglobulinemia, cold urticaria, Raynaud disease.
Okay.
You also have to be cautious with active shingles, unless, of course, your plan is to specifically ablate the dorsal root ganglion to treat that exact pain.
And what about major complications outside of that insufficient freeze? How common are they?
Extremely rare. The literature has, I think, 1 recorded case of an abscess. Most of the adverse effects are minor and temporary localized pain, numbness, swelling. But, like we stressed at the top, the real clinical failure point, the thing we work hardest to avoid, is that Sunderland Grade 1 injury that leads to worsening pain.
It's clear that interventional cryoneurolysis is not just a new trick. It's a specialized approach that relies on this synthesis of advanced imaging CT for the deep targets and a deep scientific understanding of neuroregeneration.
Specifically targeting that regenerative Sunderland Grade 2 sweet spot.
Right.
And it's a perfect example of policy-enabling progress. That shift by CMS to approve specific codes made it financially viable, and that's what unlocked its integration into palliative care, interventional radiology, and now even these new frontiers like metabolic health.
It really is the alignment of pathology, technology, and regulation. But despite all this incredible precision, there is still one fundamental challenge that we want to leave you to think about.
Yes. Current cryoablation devices are what we'd call purely output devices. They regulate the cold coming out of the probe tip with incredible consistency, but the operator still has to make an educated guess about the actual in vivo temperature being achieved right at the nerve.
So many variables. The nerve's size, its depth, the blood flow warming it up.
All of it. So the final provocative thought is this. Imagine the next generation of this technology. What happens when we move beyond just regulating the output and we start incorporating real-time in vivo temperature sensing right at the nerve? It's amazing what we could achieve. That's it. Thanks for listening.
This is Dr. Rusty Hoffman, and that's a wrap from Wisdom Radio. Find cutting-edge insights through our rapid-fire videos and community forum at medicalwisdom.ai. And remember, knowledge is the best medicine.